Good morning, everyone. It is my pleasure to start the morning plenary session, session 1. First of all, my name is Corey Howell. I'm the Capacity Building Assistance Manager for DC Engage, and we're very happy to have everyone here today. Thank you for coming out. It is my pleasure to introduce you to two speakers for this session, monkeypox and harm reduction. And so our first speaker is Jason Beverley from the DC Health and Wellness Center, a part of the DC Department of Health. Jason is a certified family nurse practitioner who serves as division chief of the STD and TB Control Division, part of the HIV/AIDS, hepatitis, STD, and TB administration at DC Department of Health. And prior to his work at DC Health, Jason worked extensively with vulnerable youth in Washington, DC, including work at a school-based health center providing adolescent primary care, and 9 years on the MedStar Georgetown University Hospital Kids Mobile Medical Clinic. And prior to that, he spent 10 years as an RN at Children's National Medical Center in the pediatric ICU. And then our next speaker, George Kerr III. George Kerr is committed to educating, training, advocating, and collaborating for social justice through harm reduction. George has a long and committed history of effectively working with some of the district's most prominent health service providers and has motivated hundreds of individuals to advocate for those who the stigma of HIV and substance abuse has silenced. George believes that together we can build a healthier community. And George serves as the co-community lead on the Drug User Health Scientific Interest Group, a part of the DC Center for AIDS Research. And so without further ado, I will let Jason start us off.
Thanks a lot, Corey. Thanks for having me here today. It's good to see old and new friends, and it's good to be together in the same space. So my name is Jason. I am a nurse practitioner. I've been a nurse and working in DC for a little over 30 years, and I am currently with the STD and TB Control Division at the DC Department of Health. Big part of my job is the oversight of the care that's given at the DC Health and Wellness Center, which is our STD and TB clinic. We're over at 77 P Street Northeast in the Noma neighborhood if you ever want to stop by. But we provide sexual health and TB services on site there. And we're going to talk a little bit about monkeypox today. And right at the outset, I can say that the very name monkeypox is not something that a lot of us are actually comfortable using. I will be using the name monkeypox, but some people prefer not to use that for a variety of reasons. So I wanted to acknowledge at the outset the uncomfortability with the actual name monkeypox. But it is here, and so today we're going to talk a little bit about the epidemiology of monkeypox here in the district, and that keeps advancing. Talk a little bit about public health recommendations. Corey, I can't get that to stop doing that. I'm not sure if I'm doing something wrong. Go back. Okay, maybe it's good. Thanks. All right. We'll talk a little bit about medical countermeasures for monkeypox, and then if we have time, we'll talk about post-exposure prophylaxis, pre-exposure prophylaxis, and antiviral treatments for monkeypox. This slide is on July 23rd, the World Health Organization declared a public health emergency of international concern related to monkeypox. This was a surprise because there's a panel of advisors typically that advise the director, and they couldn't come to a consensus about whether monkeypox met a public health emergency of international concern criteria, but he was in favor of declaring it that. And we think it does send the right message, because this is an unprecedented outbreak of monkeypox. Previous outbreaks have been much smaller, much more localized, and this has been a worldwide outbreak. The Department of Health and Human Services declared a public health emergency here in the United States shortly after that on August 4th. This slide, it shows the red circles on this slide shows the widespread nature of the current outbreak of monkeypox. The yellow circles on the map are areas where monkeypox previously had been endemic. So it had been found only periodically in these countries where the yellow dots are, whereas the red dots showed the remarkable spread of this outbreak of monkeypox. Looking at the makeup of where monkeypox is found in the United States, on this map, the darker the blue, the higher the absolute number of cases of monkeypox. So even though you can't see DC there, we would be definitely in the dark blue. Even though we are relatively small compared to other states, we have more actual cases, absolute number of monkeypox cases, than all but 7 states in the US. So we have the highest case rate per capita when compared to other states. Looking at the epidemiology of persons with monkeypox in the US, this is through the end of July. It's hard to see this slide, but basically nearly all the cases are in men, and it is affecting people of diverse racial backgrounds. If we look at the district, as of yesterday, we had 405 cases of monkeypox. This slide is a week old, actually. And one thing I wanted to highlight is we have at DC Health now, if you go to preventmonkeypox.dc.gov, we have weekly updates of the characteristics of monkeypox in the district. So you can see actual case counts and characteristics of people with monkeypox on preventmonkeypox.dc.gov. It's updated every Wednesday. I think of note on this slide is that almost 70% of the cases of monkeypox in the district up to this point have been in people ages 25 to 39, so a grand majority in young men. This shows race and gender identity breakdown, highlighting that nearly all the cases are male. Sexual orientation is not shown on this slide, but I can tell you that with the exception of a small handful of people, nearly all the cases have been in men who have sex with men or trans women having sex with men. Data shown in a different way. This is characteristics of monkeypox cases in DC through August 9th. It's a little hard to see, I know, but this slide does show ethnicity. About 16% of cases in the district are in patients who identify, in people who identify as Hispanic or Latino. And also of note is that nearly one third of the cases through August 9th were in people living with HIV. Talking about where we're at with monkeypox vaccinations, all of the doses of vaccines that have been given in DC up to this point are the Jynneos vaccine, and we'll talk about what that vaccine is in a few minutes. This shows age range of people who have been vaccinated in the district through last week, through the 16th of August. So unlike monkeypox cases, the age range of people getting vaccinated is a bit broader. Only about half of them fall into that 25 to 39 year age range. As of the 16th, we had given a little over 16,000 doses. I can say as of yesterday, we were at almost 20,000 doses of vaccine administered in the district. Gender identity and race of people who are getting vaccinated in DC. One thing that I wanted to highlight about this slide is that just 21% of folks that have gotten vaccinated to this point identify as African American, and this has actually improved, but shows an opportunity for more improvement. Looking at the epidemiology of people who have already been vaccinated in the district, this data is as of the 9th. Shows ethnicity. About 14% of people who have been vaccinated identify as Hispanic or Latino. I did want to note that the characteristics of people being vaccinated will likely change given the recent expansion in eligibility criteria that DC Health announced. So now individuals who live in the district, work in the district, are students enrolled in the district, or persons affiliated with DC Health programs that receive healthcare services in the district, all people of any sexual orientation or gender who have had multiple sex partners in the past 2 weeks, sex workers of any sexual orientation or gender, or staff of any sexual orientation or gender who work at establishments where sexual activity routinely takes place, all are eligible. So we think there will be a more a more heterogeneous group of folks getting vaccinated based on this expanded eligibility. I'm going to talk a little bit about public health recommendations and isolation recommendations as it relates to monkeypox, because this has been really burdensome for people. Basically, initially we were instructing all persons who had monkeypox to strictly isolate at home until all lesions on the body were healed, scabs had fallen off, and new skin had formed underneath. In many cases, that can take 2 to 3 weeks. So we were literally asking people to stay in their house and not go anywhere for 2 to 3 weeks. And frankly, it's very difficult for people to do that, and people don't adhere to that. And so now that we've learned a little bit more about what the most high-risk activities are to spread monkeypox, the CDC came out with new recommendations on August 2nd that acknowledge the difficulty in strictly isolating for that period of time. Basically, the difference is while people are having fever, respiratory symptoms, sore throat, cough, and the rash, they are supposed to strictly isolate. After those fever, respiratory symptoms, cough, sore throat, after those resolve, but still while the rash is there, people can go out as long as they cover the lesions completely and wear a well-fitting mask. We still are asking people to limit activities to only what they need to do when they go out, and certainly avoid intimate contact. But this is making it a little bit less burdensome for people who have monkeypox to be able to live their lives while the lesions are healing. What remains in place, though, is until all symptoms of monkeypox have resolved, until those lesions are all healed, people are still not to share items that have been worn or handled with other people or animals. People are to launder or disinfect items that have been worn and clean surfaces that have been touched. Avoid close physical contact, including sexual or close intimate contact. Sharing utensils or cups. Avoiding crowds and congregate settings, and of course, frequent hand sanitation. Talking about specifically monkeypox considerations for harm reduction, it is possible that sharing smoking or injecting equipment puts a person at higher risk of getting monkeypox. There are a lot of things we don't know for sure, so you'll hear me say we think it's possible, we think this is the case. So we do think that's possible given that other prolonged contact and sharing utensils, sharing articles of clothing has been shown to transmit monkeypox. So we think sharing smoking equipment could pass monkeypox on. People we know who do sex work are thought to be at higher risk for monkeypox. And regarding illness after infection, the data that we have available currently indicates that people with advanced and uncontrolled HIV can be at higher risk of severe or prolonged monkeypox disease. Diagnosis may be more difficult in people living with HIV because the rash can present in an unorthodox or unusual way. And there are also definite implications for the drug using and recovery community as it relates to institutional settings and outbreaks there. So what can we do about monkeypox? Well, we do have medical countermeasures that are being shown to work. So the vaccines and medications that we'll talk about today, it's important to note that these were not developed for monkeypox. These were developed for smallpox, but we are using them in the beginning of the fight against monkeypox, and we believe that they work. But in most cases, they are not FDA approved. They are being used under expanded access investigational new drug protocols, so EAIND protocols. So what are they? Well, we have, as a reminder of how, I don't know what happened to my slide there, but how important and effective vaccination can be, this slide is supposed to be a picture of Edward Jenner administering a smallpox vaccine in the late 1700s. This is often thought of as the first successful vaccine and led to the eventual elimination of smallpox in 1980. Today, newer generations of vaccines and medications that were developed for smallpox originally are stockpiled in the strategic national stockpiles maintained by the CDC, and they're available for request by health departments. So what are the countermeasures? Well, we have vaccines, we have antiviral medications, and we have immunoglobulin. Mainly, at this point in the monkeypox outbreak, we are using mostly the Jynneos vaccine and the antiviral medication tecovirimat, which is also called TPOXX. So we're going to talk a little bit about each of those. Jynneos is a vaccine that was licensed in 2019, and it is a live, non-replicating vaccine that was approved for use in smallpox, but has emergency use authorization for monkeypox. Non-replicating means it's not like that old smallpox vaccine that some of us got up until the early 70s, where you have a pockmark there and where there's an actual take, we call it. In other words, there'd be a little lesion that developed there and that could actually be contagious to other people in the household. And there were a lot of people who couldn't get that type of live virus vaccine. Jynneos is not that type of vaccine. It is a live vaccine, but it is non-replicating, which means that people who have eczema and other skin conditions, people who have HIV and other immunosuppressant conditions can get this vaccine. So that's why we're using it and not the older version of the vaccine, which we call ACAM 2000, because there are a lot of contraindications for that vaccine. Depending on how severe the outbreak gets, we may have to revisit the idea of using the old vaccine because we have many more doses of that than we do Jynneos. But right now we have enough Jynneos available that we're not using the older version yet. Tecovirimat, TPOXX. TPOXX is a antiviral medication that was developed after the eradication of smallpox for the treatment of smallpox. So you say, well, why did we develop a medication for smallpox that when it was already eradicated? Smallpox does still exist in labs, and there's a concern about it being used as a weapon of bioterrorism at some point, so we do need to have prevention and treatment for it. And we're thankful that we do, because it appears to be working well against monkeypox. There's an IV and an oral preparation of tecovirimat. The evidence for tecovirimat for monkeypox treatment comes from animal studies that suggest there is a mortality benefit, and from case reports we have now in humans that it is working to prevent progression to severe disease of monkeypox. There's very few contraindications. It has not been studied, though, in pregnant women, breastfeeding women, and in children, but we have had occasion to use it with a few children, and they did not have significant side effects attributed to the drug. It must be taken twice daily for 14 days, and it's supposed to be taken with a fatty meal. That is, can be difficult for some people who don't have regular access to food, people with unstable housing, things like that. So who should get the Jynneos vaccine for post-exposure prophylaxis? So in other words, if people, who should get it for post-exposure prophylaxis are for people who have intermediate or high-risk contacts of confirmed cases of monkeypox. So this means if you get the vaccine within 4 days of being in close contact, it decreases your risk of getting the infection significantly. If you get it up to 14 days post-exposure, it can decrease the severity of the illness if you get monkeypox. So that's Jynneos vaccine for post-exposure prophylaxis. Who should get Jynneos vaccine for pre-exposure prophylaxis? These are people who are working in labs handling monkeypox specimens, or people who work in research laboratories, or certain healthcare and public health response team members who've been designated by public health authorities to be vaccinated for emergency preparedness purposes. So what's not on this list is regular frontline healthcare workers or folks like us in the room now. We are hopeful that we will be prioritized for vaccine once more vaccine becomes available. And who are we treating for monkeypox? People who have coexisting immunosuppressive conditions, including people living with HIV, people who have genital or perianal lesions that are, have been shown to be quite painful and can lead to needing to interact with emergency rooms and hospitals for pain management, and children or other people who are considered vulnerable and potentially could have progression to severe disease. So those are the ones who we're prioritizing for the tecovirimat or TPOXX treatment. That's the end of my slides. I look forward to discussion now with my colleague here, George. And so I'm going to step down and sit over here.
While they're pulling the mics together, I just have a few comments to make. I'm really looking forward to the conversation that we're going to have. You know, I first learned about monkeypox, or mpox as I call it, on June 28th. I was headed to Kentucky for a church conference, and I was at LaGuardia, and at that day we had 5 cases. And it's amazing that today we have over 405 cases that we know about. And so we have an epidemic that really reminds, I call it an epidemic, public health calls it an outbreak. But it reminds me of the early days of GRID and the early days of AIDS, the stigma, the missteps that we have taken as public health, and naming it from the federal government that this is primarily with gay men. And it is astonishing that after 40 years of stigma within HIV, we're still having this conversation about stigma and how do we deflate that. So that's why 99% of the time I call it mpox. Occasionally I will mess up, I'm human. But the name is just so stigmatized that we need to readdress that. And I'm extremely concerned about our harm reduction population. The isolation period that you have to go through, and the mental health. We have to stop and think about the mental health. They're already dealing with so much. Now it's one more thing. So we don't have a system built in place to help those individuals with mental health. And what do we do with someone that's unstably housed and don't have a place that they can go for 2 weeks to take the medication? And so, you know, we've had this program for COVID. We need to expand it and add mpox to it. And I don't know, it may be in works, but from the community, I have not heard that. And so, and I will just leave it there and look forward to our conversation. Thank you.
So we thank Jason and George for that insightful conversation. Do we have any questions from the audience? Okay.
My question would be, why isn't it why isn't it being pushed, different protocols for monkeypox? A lot of people are not hearing about it, especially healthcare providers. They're not speaking on it. It's really like, from my understanding, I had to do my own research on it. Is it when hetero folks or people from other communities start catching it, like it's going to be more of a problem because like fellow peers, fellow friends think it's just something that gay people should worry about, people that's of the queer experience should think about. But you know, it's an issue for everybody because like I see how you was like saying in your presentation, like you can catch it through lesions from touching people, from touching surfaces, but people are still thinking it's just a STI, just like you were saying with the HIV. So I was wondering, like, is it because it's only affecting a lot of people of marginalized communities? That's why it's not like really being spoken, or that's why it's not any protocol pushed on it?
Those are great. You just said a mouthful. So, right, I think we have had from the CDC on down difficulty in figuring out how to message correctly. When I'm talking to patients, I want my patients to know definitely the facts that I know up to this point. The facts that we know up to this point is that the majority of people who have gotten monkeypox are men who have sex with men. That's just the truth. We need to know that as members of the MSM community, that we are the ones right now who are getting it. But we're not the only ones who will get it. We've already had a handful of people that aren't MSM in the district get monkeypox. And I do think, to your point about is it because mostly MSM or marginalized communities who've gotten monkeypox? Is that why we're not hearing more about it? I think that's possible. It's too soon for me to say for sure where we've dropped the ball in public health, but I'm sure the ball has been dropped. We are struggling to get a coherent message about that doesn't stigmatize it as just a gay disease, but that does tell the truth to people who are at most at risk, so that they can do things that mitigate their risk. They can change sexual behaviors if they want to do like a harm reduction strategy for monkeypox. They can get vaccinated and have access to the vaccine. You know, I know George is going to share an experience about the immunization, about getting access to the vaccine that has been frustrating for some members of the community, especially early on when we didn't have as many doses. So I know that's a long-winded answer to what you're saying, but the majority, again, what we know now is that the majority of people getting it right now are men who have sex with men, and most of the patients that I've seen have gotten it during sexual or other intimate contact. But we have to say that there are other ways that you can get it, other ways you can get in contact with those lesions that could transmit it.
One more thing. So I heard that we had more vaccinations, but they were expired. If you believe like if those vaccinations weren't expired, would it be more people getting vaccinated besides just men who are sex with men? Because like it was supposed to be weird times that I forgot the exact numbers in the millions that they let the monkeypox vaccinations expire.
You know, I really don't know the answer to that. I'm sorry. We haven't had vaccines expire in the district. I can comment on that, but I'm sorry, I'm not familiar with that story.
I'll start off by saying that the federal government has really taken a lot of missteps. We see it on a daily basis in the media, on the federal level. On the local level, we had a press conference with Dr. Nesbitt back in June. I went back to my office and immediately signed up for it. And as of today, I have not heard anything from that. sign up. So I think that there are some areas, particularly in communicating back to the community what's going on. And I have to say, right now, I'm learning about updates through Twitter. And that is not the public health message we need. I'm a part of a group that is calling for a point person that will directly talk about updates and update the community and not in a hashtag. And so, and then I heard last week, I chair for the DCC, the Community Partnership Council. I heard loud and clear from women, why aren't we talked to? This is going to impact us very deeply. And it's the same thing with transgender women. You're not talking to us except talking about sex. But there is a lot of miscommunication out there that needs to be fixed so that we can get a grapple on this.
I think you can go ahead and just speak up. Oh, sorry, I'm sorry.
Hi, I just want to say thank you so much for talking about this conversation. I've been doing this work since 1986 over DC General Hospital, and I was around when we had the outbreak of HIV/AIDS. Thousands of African-American intravenous drug users and black women died because we didn't educate the community the right way. Even though we have technology and people look at their telephones and their phones and texts, we still don't get it. And I'm sorry to hear that you said you signed up. Many of us in this field, we go over and beyond. When they opened up the open clinic, the walk-in clinics, we walked in the clinic. So you can get it. You just gotta go out and put yourself first. It is always spreading in our communities in ways where it's such a stigma, because thousands of us died. I remember we were losing 5 and 6 intravenous drug users a week. And in the black church, many women died because the secret of bisexual men, women who were married, then it came out. So I think this time, if I could have a voice to the DC Health Department and HAHSTA, please put your feet on the ground. Put the outreach workers out there. Go knock on those doors. The same way we put those door knockers on. Let people know. Because the stigma, there are a lot of people in our community that have it, but they would dare not tell anyone. And our senior population. Seniors are not thinking, I shouldn't touch this, I shouldn't hug my grandchild, I shouldn't do this. So they got it. Our numbers are much higher than what we're presenting. So for those of you who have not got it, go to the walk-up clinic. They're every Friday. They're there. Go, smile. Don't worry about the stigma. Your life is more important. Thank you.
Thank you so much for bringing that up, because I left that out of the presentation. From 12 noon to 8 p.m. on Fridays at the 3 large monkeypox vaccination clinics in the district is set aside for walk-up. So thank you for that.
I just wanted to ask, us here, we're on the ground with the community and with the people every day. And I'm just saying personally, because of the way that the message is being sent out, people tend to think it's not me. And it hurts me that history hasn't taught us anything. And I'm afraid that a lot of people, I'm a heterosexual woman, I'm still offended when HIV first hit the scene, the way that heterosexual women were dealt with. And we've seen what happened. We became some of the most highly infected. And so I'm just asking, from a person that's on the ground with people every day, what can we tell them to inform them? The person that just spoke, I took a few tips from that, because people don't know. People don't know. And I guess I'm just the voice trying to cry for the people on the ground level.
I think you took the first step and you showed up here today. And part of this is being able to listen and answer questions. And so you're getting the knowledge here today, and that's going to be really important. But then also, you're going to have to lobby and get more information out there from the DC Health, from the City Council, to the federal government.
Hi.
That's the activist in me, sorry.
Okay. Oh, okay. Hi. I was thinking about weeks ago, not maybe almost a month ago, I received an email about signing up, pre-registering for the Mpox vaccination. At the time, I saw the criteria, those for people, for men who would have having sex with men, sex workers, and people with compromised immune systems. I signed up for it, and I noticed I had not heard back from them, and so when I reached out to them via email, the response was that, oh, we have changed the criteria. They don't have people living with compromised immune systems anymore on it. Can you tell me why they did that?
So,
Thank you.
yeah, so I believe that the reason why we were really trying to expand the criteria by not limiting it to those smaller groups of people. So that's why at preventmonkeypox.dc.gov, the eligibility criteria language changed, as the goal of that was to expand the people who could get access to the vaccine, because we have more vaccine now. And we have a new administration method that allows us to use less of the vaccine volume to achieve the same immune response. So now we can just use 0.1 milliliters intradermally, so just underneath the skin, instead of 0.5 milliliters subcutaneously. So we'll be able to get 4 to 5 more times, 4 to 5 times more people vaccinated with this new administration technique. But I believe, although I was not directly involved in changing that on the website, I believe that's why that language was changed in that way.
So does that mean that if you live with a compromised immune system, where do you go?
You are still prioritized for vaccine if you're living with an immunocompromising condition. So any of the 3 large vaccination clinics, you can register at preventmonkeypox.dc.gov or can walk in on Fridays. It's on the web. It's on preventmonkeypox.dc.gov. One of them is the old Casa Ruby building on Georgia Avenue. There's one on I Street Southwest, and there's one in Ward 8 on MLK. It's preventmonkeypox.dc.gov.
So the problem right now is the medical mistrust. And so when you switch and say you change in the regimen, there's a lot of people that don't believe that. So part of the education and harm reduction individuals, we have to be able to tell people, yes, the smaller dosage will work. And so there needs to be better communication on why that happened.
Okay. So
Agreed.
Okay, thank you. So let me ask a baby question, okay? So we're fighting COVID, got a new strand that came, people are getting vaccinated, all of which is going on, and then last Monday or so, Tuesday maybe, I hear the mayor say, we've started this for monkeypox. But she, or no one else, said, there's a new issue we have here, and it's called monkeypox. People, I'm there, I'm in the community every day. I have no idea, no education about it, nothing going on, no posters, no flyers, no hospitalization information. All I see is, and I'm glad, information about COVID. Where did it come from? Where can I get cured? How can I get services? Who's treating it? I'm so sick, I'm at the hospital. Where is that information?
So in DC Health, trying to centralize that to that one website is one attempt that we're making to provide a repository of the questions that the answers to the questions that you just asked. But I can say, even as a member of the healthcare community, that there are times when we're also seeking up-to-date information from our national colleagues. And it is such a quickly evolving outbreak that we are struggling to keep up. We get new information as we go, and we're struggling to then turn that information out and make sure the public has it.
And I really appreciate DC Health and the administration on doing that. And, you know, as we're finding this out, we just found out about polio. So we have these emerging outbreaks that are happening. So we need to be ahead of the game talking about these in advance. You know, I don't know, polio and HIV. Is there a risk? You know, trying to get that information ahead of time instead of finding out on the news outbreak here in DC. And one of the areas that, with the community that I'm a part of, we're very concerned about back to school and our young kids. And so there needs to be better communication on that as well.
Okay, so we have about time for one more question.
Thank you so much for your presentation. So I have a question in regards to the vaccination itself. Are there any serious side effects to those who are receiving these vaccines? Have you seen any side effects after people receive the vaccination?
Yep, great question. So we've given a lot of these doses now, and by far the biggest side effect that we've gotten complaints about is soreness at the injection site. So this had been a subcutaneous injection, so typically given in the back of the arm into the fat of the back of the arm, and soreness at the injection site was the major complaint. We haven't gotten very many other complaints about side effects. So unlike the COVID vaccine, for instance, which we often have people say they have muscle aches and chills and a low-grade fever, I haven't seen that with this vaccine, so that's encouraging. I think it's too soon to say with the new administration technique, the 0.1 milliliters under the skin. I think we'll see if we get different complaints with the new administration technique.
Wonderful. Well, I want to thank Jason Beverley and George Kerr III for this insightful discussion, as well as you all for asking the questions that you did. This concludes this session. Of course, feel free to ask the question speakers if you didn't get to ask your questions, and we'll reconvene in here for the lunch plenary session.